So the radiation dose de-intensification clearly went well. You're looking at a different study here, looking at elimination of the chemotherapy of the cisplatin, and that did not go as well. In particular, at the bottom left, local regional failure was quite a bit higher in patients who, for whom the chemotherapy was omitted. That was not clearly reflected in the survival curve shown at top right, but that may be a consequence of salvage. When chemoradiotherapy or radiotherapy alone for half of the patients doesn't cure people, you can come back and salvage a cure with surgery. The problem is those surgeries are dramatic and brutal compared to what you would have done if surgery was the upfront curative modality. And so the failure here on local regional failure is a big deal. And you can see a trend in the wrong direction for progression-free survival shown at top left. And so we are more hesitant about eliminating or reducing the dose of chemotherapy than we are about reducing the radiation dose. This is a much more complicated study. I apologize for that, ECOG 3311. But in editorializing which of the many important studies to share with you, this is actually a really important one. So I'll walk you through the design. Basically, what happened here was that the lowest risk patients after surgery were observed. The highest risk patients got standard adjuvant chemotherapy and radiation at very standard doses. And those with an intermediate risk were randomized to either the standard adjuvant radiation dose 60 gray or a dose reduction of 50 gray. I want to comment here on surgery before moving forward, because I think that if we're focused here on quality of life, we need to not lump all surgery together, because not all head and neck cancer surgery harms quality of life to the same extent. Happily, over the decades, chemotherapy supportive care has improved, particularly for nausea control and amelioration of renal problems. Happily, radiation has improved. The ability to focally deliver it has improved. And I want to acknowledge that surgical standard of care has improved as well. More specifically is the advent of transoral surgeries. So these are just what they sound like. Instead of splitting the jaw and coming in from the outside to in, transoral surgery, be it transoral laser or transoral robotic surgery, goes from the inside to out for the oral cavity and the oropharynx, meaning the tonsil and base of tongue, and sometimes even high hypopharynx cancers. I'm not a surgeon, but I do admire these surgeries. They have a whole lot less blood loss, typically on par with a blood draw, not with one of the old school surgeries. The cosmetic defect from the removal of the primary tumor is 0. And the functional outcomes are quite good compared to the older surgeries as well. The recovery time is faster, hospital stay is shorter. So these are better surgeries. As a medical oncologist, I kind of vaguely think of transoral surgery as de-intensified surgery in terms of the risk of harm to the patient. And these are really the kinds of surgeries that are most relevant for the HPV positive cancer patient. Overwhelming majority of cancers here are the oropharynx and base of, the base of tongue and tonsil, which are very amenable to these kinds of surgeries. So onto the data. Of course, arm A, the low risk patients did the best. This is not necessarily reflective of that people do better if you leave out radiation. It's reflective that this is a low risk population. And like the first study data I showed you, it shows you that the de-intensification here did not, still had a positive outcome. In orange, we see that the highest risk patients do the worst. Of course, the highest risk patients did do the worst. But what's really interesting here, to me, most instructive, is how similar these green and red curves are. It's the same curve, right? They cross over each other a few times. There's no difference between these curves other than what random noise gives us. Suggesting, this wasn't a phase 3 study, but suggesting that it may be safe to reduce the adjuvant radiation dose in these patients from 60 to 50, and the decrease from 60 to 50 is meaningful. Just like in the first study I showed you, it was meaningful going from 70 to 60.